Welcome to this IHF webinar on HFrEF and chronic coronary syndrome from GDMT to optimal revascularization strategy and return. My name is Amina Rakisheva and I'm a heart failure specialist from Almaty region, Kazakhstan. So the learning objectives are following. First, to discuss the selections of the patients with HFrEF and CAD who may benefit from revascularization, to debate the most appropriate revascularization strategy to these patients, to provide an update on guideline-directed medical therapy following revascularization. Together with leading experts, we will focus on practical, patient-centered approach for patients with HFrEF and chronic coronary syndrome, aiming to improving symptoms, quality of life, and long-term cardiovascular outcomes. Here's the team. My co-chair, Martine Gillard from Brest, France, our discussant, Ahmed Benis and Sabine Bleitzifer, and our speakers, Emiliano Fiore, Marta Belmonte. Welcome to all of you. This is an interactive session. Please don't miss the opportunity to share your opinion and ask your questions via chat box. This is a very interesting webinar because we are facing with this type of patients very often. And that's why we thought it will be important to discuss this, clinical, real world practice together with you, with our outstanding speakers, right, Martine?
Yes, I think it's very, very important. And the best way to do that is to share with you a case dedicated to that, because I think it's more easy to understand, and I think it will reflect your own practice and what to do in this kind of very difficult patient. Because for me, I am not a specialist about heart failure. However, I have sometimes to perform and to decide how to treat this coronary artery disease. So it's why I think it's very, very important to begin first with clinical cases.
Let's kick off the session with an interesting clinical case from Rome, selected by Emiliano Fiore. Please.
In our outpatient clinic, complaining worsening dyspnea, New York Heart Class Association 3, worsening in the previous 3 months. And the past medical history of this patient was remarkable for arterial hypertension and chronic kidney disease. His physical examination revealed blood pressure of 120/60, a heart rate of 70 beats per minute, a third heart sound at auscultation. And this is the ECG, which already tells us a bit of a part of the story, because it reveals some signs of possibly previous myocardial infarction. And concerning lab tests, 11 grams per deciliter of hemoglobin, increased creatinine, so CKD, and NT-proBNP of 1500. In our patient clinic, we performed transthoracic echo, which demonstrated a slightly dilated left ventricle with severely reduced left ventricular function, 25% of ejection fraction, preserved right ventricular function. We can see already left ventricular wall motion abnormalities in the apical region, anterior region, and lateral region. Concerning diastole, the patient presented elevated filling pressures with an E on E prime on average of more than 20. Strain confirmed the regional wall motion abnormalities and the reduction in left ventricular systolic function, and myocardial work confirmed the presence of a severely reduced myocardial work efficiency. So, in the outpatient setting, our working diagnosis was of HFrEF with an ejection fraction below 30%, with segmental left ventricular wall motion abnormalities. We decided at that moment to start GDMT with the 4 pillars all together. So bisoprolol, furosemide because of elevated feeling pressures, dapagliflozin, and ACE inhibitors, and spironolactone, 25 milligrams. However, since the clear evidence of segmental abnormalities in left ventricular kinesia, we decided to schedule a programmed admission for diagnostic workup for this patient. However, only 2 weeks later, the patient was urgently admitted to our presenting to our emergency department in pulmonary edema. So with a worsening heart failure event, despite the initiation of GDMT, the patient was symptomatic at rest. He referred poor GDMT tolerance due to recurrence of hypotension. Blood pressure was still acceptable, heart rate on the upper side with jugular vein pulsatility. And if we look at lab tests, we can see a worsening of kidney function, potassium above 5 milliequivalents per liter, reduced net sodium, and an NT-proBNP of more than 5,000. The patient eventually received invasive coronary angiography, which showed a 3-vessel disease with total occlusion of the right coronary artery. And looking at the left system, it reveals the presence of a calcific lesion of the distal left main, extending to the circumflex, and a severe lesion of the mid-LAD. At this point, a left heart catheterization has been performed, showing a remarkable increase of left ventricular filling pressures with an LVEDP of 35 millimeters of mercury. At this point, our colleague interventional cardiologist stopped and the patient was sent for multidisciplinary discussion.
So thank you very much, Mariano. I think it's really interesting cases. But I would like to ask Ahmed Beniz you, how are similar patients currently treated in your country and routine clinical practice?
Thank you, Amina. It's a mirror of what we see every week in our practice in Morocco or in income health system. The first issue is to access to GDMT. And in Morocco, we have 4 pillars of the treatment. We have beta blockers, bisoprolol. We have the SGLT2, dapagliflozin. We have also MRI. We have spironolactone in same dose. But perhaps in our choice, the first choice, it's sacubitril valsartan. It's we have now the trial that it's better than lisinopril, and our best on first choice it's sacubitril valsartan. We have a trial like Paradigm or Paragon or Titrate, and it's more efficacious, more efficient. And our goal in this patient is to reduce hospitalization, to reduce NT-proBNP, to reverse remodeling, to increase our ejection fraction. And it's very important for us to begin in the treatment in hospital initiation. In that, it's very important to put 4 pillars in parallel, not in sequence. And there is some barrier in this patient because this patient is very high risk, renal barrier, renal impairment, problem of blood pressure, and problem of potassium, and we must close surveillance of that. The problem also, we have some problem with medical inertia in this kind of patient because the patient is very high risk, and more risk is more the risk, more inertia, medical inertia is present. We have some heart team, medical heart team, because this patient is challenging. It's a patient high risk at surgery, it's high risk at PCI, And we must deal this case, have a discussion with a heart team. I think that's the kind of this patient need more than one doctor. We need 3 or 4 doctors to have a good decision. And also, we use risk stratification, not only one risk stratification, one score, but many score. I think that we're going to have a discussion about that. Syntax score, STS score, MAGIC score. And in my view, this patient is at a high risk. It's a mirror of our practice. It needs more efficient. We need to go with medical therapy with 4 pillars. We must deal with blood pressure, with potassium, with renal impairment, and we need to go quickly in this patient. We need to go with the 4 pillar in parallel, not in sequence, and we must need to have discussion in this patient because our goal, it give this patient all kind of success to be in good life, quality of life, and reverse remodeling, improve ejection fraction, and the best important thing, to reduce his mortality and his hospitalization.
Thank you very much, Ahmed. But now, Emiliano, looking back at the initial presentation, were there any missed clinical or diagnostic signals that may have influenced to the patient's journey? What do you think?
Thank you, Amina, for the question. I mean, I don't think there is a single missed opportunity in the management of this patient, but it's of course a multifactorial combination. To summarize, I would say I think we honestly underestimated the clinical risk profile of this patient. Despite its outpatient presentation, we were dealing with already a patient in worsening, already in almost over clinical decompensation. So maybe looking back, what would have been a good choice, even if the patient is an ambulant patient, would have been a good opportunity and a good clinical window to hospitalize him urgently and proceed straight forward for the diagnostic workup and also volume and medical optimization in hospital. But of course, this is much easier with the far sight of the future. So I think we missed the clinical risk profile of the patient overall.
Thank you, Emiliano.
Yes, and I just want to say to the audience, do not hesitate to ask a question or to make comments. It's very, very important. You have the opportunity to discuss with experts, and I think it will be great for each other. And I would like to ask now, because it's my topic, I would like to ask to Sabine about the revascularization of this patient who have HF and plus coronary artery disease. So we know that we have in this kind of patient 2 types of revascularization, PCI or CABG. And could you remember to us what is the advantage, the limitation, how to select the patient according to if you want to perform a PCI or if you want to perform a CABG?
Thank you, Martine, very much for this question asked to a surgeon. So CABG versus PCI, I think the big advantage of CABG is that more complete revascularization can be achieved and a potential survival benefit at the long term can be achieved. There are data in patients with reduced ventricular function, propensity match data, demonstrating that the benefit of surgery is always at the long run. The limitation of CABG is at the same time the advantage of PCI, as the surgical risk always is the limitation for us. And the risk is defined by patient's condition and especially comorbidities, I would say in this patient, especially the renal dysfunction. And when I go to patient selection for CABG or PCI, I would always take into account lifestyle considerations, life expectancy. What does the patient expect to achieve after a procedure? How is his symptom burden? And he always has to know that a surgical procedure is an investment for potential long-term benefit. And in addition, I would like to share with you that when it comes to surgery, we always have to consider what is the best option for these patients, because we have several. So is arterial revascularization important? I would say not so much in a 70, 80-year-old, but is off-pump surgery available and feasible in the patient, or beating heart? Because both options are less invasive, I think, than surgery on the arrested heart.
And do you think it's very important to discuss this kind of patient between, in our team, between surgeon, PCR, interventional cardiologist, and cardiologist? What do you think? You think it's mandatory or?
Sure. So I think more and more heart teams have a structured coronary board also, where these types of patients are discussed.
Yeah, I think it's very important, because at the beginning of our history, we do it in each side. So I think now we have a good evolution, and I think this our team discussion, we read it in the guideline, but I think it's very, very important because we need to have the size between with the eyes of a surgeon and the eyes of an interventional cardiologist. So another question for you, Sabine, it's about this patient has a very bad LV functions. It's very, very low one. And if you decided to perform a revascularization, when do you use a mechanical circulatory support for this revascularization? And what is the rationale? What is how do you define? How can you explain to us?
Yeah. So there is not really a lot of data about that. It's just some case series and personal experiences. But the rationale behind it is that if you do mechanical circulatory support in advance of such a procedure, you can precondition the patient for the procedure and help recover him maybe from decompensation, and to bring him into a better condition for such an invasive procedure. And if you stay with the MCS during the procedure, the rationale is to avoid low output after the procedure and avoid cardiopulmonary bypass weaning failure after the procedure. So there is really not a lot of data. I found some case series demonstrating that patients who receive mechanical circulatory support, which is very often an Impella support, pre or intra-procedurally, do better than patients who receive it afterwards, which is logical, because patients needing mechanical circulatory support afterwards are the higher risk patients. And I think there is much more data for the PCI, which has proven feasibility for patients of this kind to do protected PCI. But still, there is no randomized trial or something like that.
Yes, so we have to tailor to our patient, and the possibility also of the center. It's a question also for you, Ahmed. In your country, do you use very often the mechanical circulatory support?
Very low cases. We have the problem of access of these possibilities. Then very, very low patient. We use most frequently medical treatment, and we evaluate the risk benefits. But in very, very, very few cases, for rare cases, and we emphasize in our country that medical treatment that put for medical therapy, guided medical therapy to follow a recommendation is very important. And we consider that it's a failure when the patient is in this case because there is a story before. And in our society, Moroccan Society of Cardiology, emphasize that we must treat patients with four pillar. If they have ejection fraction loaded, we have a reduction in ejection fraction. We must over than medical inertia. It's all the time. It's too difficult, but there is patient with kidney disease, with hypertension, with frailty. We consider all that, but in our practice, the most frequent is medical treatment.
Thank you. So, Amina, I leave you the word.
Thank you very much. I think it's a very nice discussion, but I would like to give the word to Marta Belmonte because maybe she will open the discussion exactly what kind of a strategy is the best option to. So Marta, the floor is yours.
Thank you very much to the organizing committee for this kind invitation and for the opportunity to discuss one of the most challenging and still debated topics in contemporary cardiovascular medicine, how to manage chronic coronary syndromes in patients with heart failure and reduced ejection fraction. After listening to this very interesting case presentation and the heart team discussion, I would like to focus on a practical question. If this patient walked into my heart team meeting tomorrow, what would I actually do? Before discussing how I would treat this patient, the first question I would ask myself is, why does treatment matter? We know that patients with HFrEF and coronary artery disease represent a particularly vulnerable population. The coexistence of coronary artery disease and HFrEF is associated with higher mortality, a higher risk of heart failure hospitalization, and progressive deterioration of left ventricular function. Recent data from Anker and colleagues show that the presence of CAD substantially worsens prognosis in patients with HFrEF and compared with a matched general population essentially doubles excess mortality. Coronary artery disease is therefore not simply a comorbidity in HFrEF, it is a major determinant of prognosis. Similarly, long-term observational data from Rusinaro and colleagues demonstrated that coronary artery disease has a profound impact on cardiovascular mortality in patients with HFrEF, reinforcing the importance of identifying and appropriately managing ischemic heart disease in this setting. When I look at our patient, I immediately recognize multiple markers of risk, both clinical factors and factors related to coronary anatomy. He is 78-year-old, he has severe LV dysfunction, CKD, and recurrent episode of acute decompensated heart failure despite initiation of guideline-directed medical therapy. If we look at his coronary, he has multivessel coronary artery disease with a large ischemic burden and he has elevated surgical risk scores. In other words, this is a patient at high risk, whether we intervene or not. Therefore, the next question would be whether revascularization can change the patient trajectory. So, as I mentioned, the next question would be whether revascularization can change the patient trajectory, and several studies suggest that revascularization may indeed improve outcomes in selected patients with ischemic cardiomyopathy. These are data coming from the ischemia trial, which have shown that the benefit of an invasive strategy appears particularly relevant among patients with impaired left ventricular function and clinical manifestation of heart failure. Furthermore, more recent analyses have highlighted the importance of achieving complete or near-complete revascularization because the prognostic benefit appears closely linked to the completeness of myocardial revascularization. This concept is particularly important in patients with extensive coronary artery disease and large areas of jeopardized myocardium, such as the patient that we are discussing today. Then the next step would be to decide how to revascularize. Historically, coronary artery bypass graft has represented the reference strategy in ischemic cardiomyopathy. The STITCH trial and its long-term extension, namely the STITCHES, which provides the follow-up at 10 years, demonstrated that among patients with severe LV dysfunction and coronary artery disease, CABG added to optimal medical therapy resulted in lower rates of all-cause mortality, cardiovascular mortality, and cardiovascular hospitalization compared with medical therapy alone. These studies established the principle that revascularization can improve long-term outcomes in appropriately selected patients with ischemic HFrEF. However, the question becomes more complex when we consider PCI. The REVIVE-BCS-2 trial challenged many of our assumptions. Indeed, it demonstrated that in patients with severe LV dysfunction and extensive coronary artery disease, PCI failed to reduce the composite endpoint of death and heart failure hospitalization and did not significantly improve left ventricular ejection fraction. At first glance, one can think that PCI does not work in ischemic cardiomyopathy, but this would be an oversimplification. Indeed, the REVIVE trial enrolled a different population compared to the STITCH trial. Indeed, patients were mainly stable and asymptomatic and was not designed to compare PCI with CABG. So my take-home message from the REVIVE-BCS trial is that PCI should not be routinely performed in asymptomatic patients with multivessel coronary artery disease and regardless of the presence of viability. So this brings back us to our patient. Although coronary artery bypass graft remains an important option in many patients with ischemic cardiomyopathy, several factors make surgery less attractive in this specific case, as also Sabine mentioned: advanced age, chronic kidney disease, recurrent decompensated heart failure, elevated surgical risk scores, and significant hemodynamic compromise. So, in my opinion, individual risk assessment is essential, and in this specific case, I would favor a strategy of protected PCI aiming at achieving the most complete revascularization possible. The next question should be, how can we perform complex PCI safely in a patient with severe LV dysfunction? And this is where the characteristics of the patient become extremely important. Indeed, we are dealing with a high-risk patient and with decompensated heart failure who would require mainly a long and complex procedure. So this is why in this case I would go for an Impella-supported PCI with the aim of achieving a procedural PCI success, aiming at complete revascularization, and I will use MCS to prevent hemodynamic collapse and also to favor a smooth in-hospital stay afterwards, facilitating the optimization of guideline-directed medical therapy. In general, when I consider the use of mechanic circulatory support in my daily practice, definitely in patients with reduced LV ejection fraction and elevated filling pressures, and there is a very practical rule of thumb that tells us that when the filling pressures are higher compared to the LV ejection fraction, then it's the right patient to consider to support with a mechanic circulatory support. I would also consider its use in complex multivessel PCI and in presence of large ischemic territory, and especially if the patient has recently been admitted for acute decompensated heart failure. The next question would be, which kind of mechanic circulatory support should I prefer in those cases? This question was addressed by the CHIEF-BCIS III trial, which was a multi-center open-label randomized clinical trial including 300 patients with severe LV dysfunction and extensive coronary artery disease who were randomized in a 1-to-1 ratio to a strategy of elective unloading with a microaxial flow pump or standard of care during complex PCI. This trial showed that routine unloading did not reduce major adverse clinical outcomes compared to standard of care. Also in this case, the take-home message from this study is that Impella is not justified routinely for all high-risk PCI, but its use should be individualized based on patient characteristics. So to sum up, considering the clinical presentation, In this case, I would go for rapid stabilization of heart failure, and after hearting discussion, I would support a protected PCI with the Impella, aiming at complete revascularization, and then I would focus for an immediate optimization of guideline-directed medical therapy. What I expect from this strategy is an improvement in symptoms, so an improvement in NYHA class, and if possible, an improvement in the left ventricular ejection fraction, and hopefully, I hope that the patient will not undergo further hospitalization for heart failure. So in conclusion, I believe that in patients with chronic coronary syndrome and HFrEF, the question is which strategy allows complete revascularization with the lowest overall risk while preserving the opportunity to optimize guideline-directed medical therapy.
Thank you very much, Marta. Indeed, this was amazing. But my first question, let's go back to the studies that you already discussed. It's about revived BCIS study. Well, actually showed no PCI benefit over optimal medical therapy in stable ischemic cardiomyopathy. So how should we reconcile this data, the neutral result, to our patient? So is the key difference is simply that our patient was acutely decompensated rather than stable?
Amina, that's an excellent question. Indeed, the revived BCS trial should be interpreted appropriately. Indeed, the lesson that taught us is that in patients with a stable ischemic cardiomyopathy and severe LV dysfunction, revascularization should not be performed routinely, regardless of viability. But it does not mean that PCI does not have a role in this patient. And indeed, in our clinical practice, we still recommend PCI in many of them. First of all, I would like to highlight some differences, some clinical differences of the patient that Emiliano just discussed compared to the study population included in the revived BCS. Indeed, the patient presented in our clinical case had a recent worsening of heart failure, progressing to acute decompensation and pulmonary edema, and he had markedly elevated feeling pressures, and most importantly, he had poor tolerance of guideline-directed medical therapy due to hypotension and recurrent congestion. Therefore, it is highly likely that the ischemic background of this patient contributed to the hemodynamic instability. So in this case, I'm pretty convinced that PCI could be beneficial in optimizing, first of all, his status symptom, and also the possibility of optimizing guideline-directed medical therapy.
Thank you.
I would like to ask to Sabine, I want to come back to you with the mechanical support. So in the SHIP BCI that presented by Marta showed that there is no benefit of elective LV unloading of a standard care in a similar population. So why Impella here over the balloon pump, for example, or not support at all? And what about this patient risk profile justify to go to departing from that neutral results?
Mm-hmm. Thank you, Martin, again for this very interesting question. So it is very important that we know there are different mechanical support devices. So the IRBP, the balloon pump, just reduces the afterload. On the other hand, the Impella really generates cardiac output, especially, there is also the 5.5 Impella, which can produce 5.5 liters per minute cardiac output. So I think this is much more effective than the balloon pump. And I think in the study, in the BCIS, CHIP BCIS study, there was a potpourri of mechanical support devices used, and that may have caused some kind of bias on one hand, and on the other hand, the endpoint is only 12 months, and I think maybe the results, or if there is a benefit, it may be more at the longer term.
Yes, I understand.
So now, Martin, can I ask Emiliano? Emiliano, if ejection fraction recovery platelets are below 35%. What's the plan for device therapy? I mean, ICD and or CRT, or CRTD timing.
Thank you, Amina, and thank Marta for this overview. Actually, this is a very important topic. I mean, what to expect from a patient who has not recovered in ejection fraction after revascularization? This is something we should keep in mind as an alert. Normally, these patients have the worst possible prognosis in the spectrum of the ischemic or post-infarctual cardiomyopathy, because it means that rather than ischemic, it's probably an underlying necrotic area from which you cannot expect any benefit from revascularization. And so in this patient, I would definitely push for fast track towards sudden cardiac death protection, so an implantable cardiovascular defibrillator. Possibly, if this has not yet performed, after a CMR to quantify scar burden, because this is actually the underlying mechanism of sudden cardiac death in these patients. And after that, we have to keep in mind that these patients could be already in the area of advanced heart failure, especially in ejection fraction cases below 30%. So already a discussion towards advanced therapy should be at least considered, especially for the younger patients.
Yes, and I would like to come back to Marta. So thanks a lot for this great overview about the data on this field. So if we analyze revived BCI and switch, point in different direction on revascularization benefits. One is positive, the other one is neutral. So but it's part a long time. So in day-to-day practice, which trial should we lean on when we decided for a patient like this? Which kind of revascularization we would choose?
Martin, thanks a lot for this question, which is actually very challenging. First of all, I would highlight some differences between the STITCH trial and the REVIVED. The STITCH trial was run almost 10 years ago with a completely different medical therapy and also surgical techniques. And it was not a direct comparison with PCI, but rather it compared the outcomes of patients undergoing CABG versus patients undergoing optimized medical therapy. So the study population included in the STITCH trial is very different from the one included in the revived BCIS. And another important comment that we need to consider is that throughout this year, medical therapy has become more and more able to increase and to improve the prognosis of our patients, also thanks to the use of ICD and CRT. The question is, we can rely on the data available, but we should definitely need more data and appropriately designed randomized clinical trial comparing directly PCI with modern technique of doing PCI and CABG with modern techniques of doing CABG compared to the medical therapy that we have now. The question is how guidelines can interpret and accept these data available in literature, where actually now they just recommend CABG in presence of reduced LV function and especially multivessel coronary artery disease, but the level of recommendation is not that high. So we definitely need more data about.
I agree.
Thank you very much, Marta, and thank you very much, Martin. So let's go back to our interesting case and to the second part. So Emiliano, again, you're back.
Let's go. So before our team discussion, we assessed viability, which is a bit the elephant in the room when discussing revascularization. And in this case, viability has been assessed via PET, In this case, what PET showed, it was quite remarkable. So a vast area, anteroseptal and anterior, a bit lateral wall of an extension of the 35% of the myocardium, which was indeed hibernated but viable. This motivated us and refined somehow our working diagnosis in a more complete diagnosis. So now we were facing a 70-year-old gentleman with worsening, and not only HFrEF, so worsening heart failure with a 20% of ejection fraction, multivessel coronary artery disease, but with viable myocardium. As already introduced, coronary anatomy was very complex, syntax score of 36, but also a very high risk morbidity and mortality operative profile with an STS score of 7.2 and a Euro score of 8.4. But looking also, on the other hand, at the inherent mortality risk of the heart failure in this patient, the trajectory is also very worrisome, because we have a MAGIC score of 17 and a 3CHF score of 40%. So pointing out the very high risk and the high risk probability for worsening events and death in this patient if less poorly treated or are incompletely treated. So the decision was to go for PCI, and more specifically an MCS, I would say an hemodynamic optimized PCI. This means that the patient admitted received an hemodynamic optimization setup, which comprised invasive hemodynamic monitoring with a 7 French Joins-Ganz catheter positioned in the pulmonary artery. And this allowed us also medical optimization with intravenous diuretics, furosemide, a low dose of sodium nitroprusside to couple the left ventricle with the afterload, and of course, a microaxial flow pump, namely an Impella CP, to unload the left ventricle that, as we have seen from the left heart catheterization, presented very high filling pressures. So, under hemodynamic support, the interventional cardiologist performed a DK crush. First, stenting the circumflex, as we can see here, and then focusing on the LAD, the interventional cardiologist stented from the mid vessel to the left main. And here we can see the final kissing balloon and the pot. And this is the final result. So revascularization of the left system. The patient has still complete coronary occlusion of the right coronary artery, which received collateralization from the left coronary artery. Importantly, back in the CICU, the patient maintained and regained hemodynamic stability, and it was possible to wean him from the MCS and from intravenous medication. A GDMT was updated, we could say, because actually we started a low dose of sacubitril valsartan and, of course, antithrombotic medications. At discharge, the patient received a plan for follow-up, including cardiac revalidation, which is recommended in this case of heart failure patients, and of course, a clinical and instrumental follow-up. 3 months later, at echographic follow-up, we can see partial but still present recover in left ventricular function, with the left ventricular ejection fraction now approximately of 35%, and still preserved right ventricular function. Okay, looking at the diastolic function, this also has improved with a EONI prime on average of less than 15. We were coming from more than 20. And interestingly, this was the longitudinal strain and myocardial work pre-PCI, which improved dramatically after revascularization, with also an increase of myocardial work efficiency. Overall, the patient was feeling better. He was now in New York Heart Association class 2, free from further heart failure hospitalization after discharge. At physical examination, he was in sinus rhythm with a good blood pressure. And of course, kidney function went a bit down. But this was also due, of course, to the introduction of the FOLD pillars at progressively increased dose. At that moment, sacubitril valsartan was up titrated. Thank you for your attention.
Thank you, Emiliano. This was indeed outstanding case, and what actually, attract what we are facing with in our daily clinical practice. But let's go for a discussion. We discussed different parts, optimal medical therapy, PCI strategy, and also mechanical circulatory support. But I would like to ask first, Ahmed, you, how should comorbidity and frailty profile factored to this specific case? For the heart team assessment and choice of strategy.
Definitely, there is many factor like frailty, like cognitive function, like renal dysfunction, pulmonary disease, diabetes, polypharmacy, and there is estimation between risk of PCI and surgery, and this presence of frailty can consider the choice. If frailty is mild or to moderate, we can go to surgery. If frailty is severe, we can go to PCI. Is life expectancy is limited, we can go just medical treatment. And we must incorporate a patient in a goal of what we want if this kind of patient. One, preservation of independence is very important. Two, symptom relief. Three, avoid all prolonged hospitalization and maintains of quality of life. I think that of these elements are very important to be considered of in this case. And I want to congratulate Emiliano for this kind of work. It's very interesting because working together is important to succeed.
Thank you very much, Ahmed. Several times you already faced, you told us about clinical inertia, but I would like also to go back to this question, specific one, and how should we, overcome the hesitancy to ensure that all the patients won't be undertreated, related or compared to younger patients, especially with this clinical inertia.
One, it's start slow and go slow. It's important. Two, separate chronological and biological age. Three, it's important to prioritize the evidence-based therapy. Four, to use structure monitoring and address polypharmacy systematically and involve multidisciplinary team. And the last but not least is to educate a patient, and the family of a patient is more important.
Thank you. Martin, do you have any questions?
No, unfortunately. So I would like to ask Emilio, because you explained to us how you follow your patient, but I would like you to summarize and to explain to our audience what clinical and diagnostic follow strategy do you use for this kind of patient, and how to perform, how to assure that there is a reverse remodeling, how to define the new treatment. Do you stop all the treatment, or how do you do with the medical treatment, and how do you when determine whether you have or not to do another revascularization?
Thank you, Martin, for this question. Actually, follow-up of heart failure patients is a huge burden. So first of all, and also connecting to what Ahmed said, I think follow-up of our failure patients should be multidisciplinary meaning that should involve a figure which is growing in Europe and in the and overall in the world, which is the heart failure nurse, which is extremely relevant, especially in a setting where we should aim for strong protocol of follow-up. So for a very rapid and complete initiation and titration of medical therapy. So first, I would say to distinguish medical up titration follow-up visit from full cardiological consultation follow-up visits. And why? Because a possible solution also to optimize resources could be to structure a protocol of up titration follow-up consultations and then achieve the maximum tolerated GDMT to reassess echo and to reassess left ventricular function, because that's the best and the optimum the patient has achieved. We cannot expect any more improvement, at least in the midterm. So to summarize, I would say involving dedicated figures in the nurse team, heart failure nurses, and to split and to reorganize the consultation pathway between up titration consultation and complete full cardiological consultations. Of course, in an ideal world, especially more advanced case, invasive pulmonary artery monitoring can really play a role in the follow-up, but this is quite costly and is not everywhere available.
Just a question for Emiliano. Have you a nurse dedicated to heart failure education or therapy in Italy?
In Italy, this is a figure in progress. There are actually plans to create a dedicated figure for this, especially for the training and the recognition of this figure. But in other countries in Europe, for example, in Belgium, there are, and these are extremely useful also starting from the pre-discharge phase to educate the patient first to what he should and especially should not do. So in some countries and also in the UK, these figures are already present and play a role.
They do an amazing job, and they have more success than doctor in optimizing the treatment of heart failure.
Absolutely.
A question for Sabine. In your center, when you decided to help the interventional cardiologist with mechanical support with an Impella, which size of Impella do you choose, and which is the people who implants the Impella? It's a surgeon or it's an interventional cardiologist? It's a practical things, but I would like to have your view.
Yes, thank you very much for this question, because indeed I think it's a little bit special at our center because we are very much in favor of the Impella 5.5, and we work together with a heart failure team, interdisciplinary, and the surgeon does implant the 5.5 Impella because we do it with a surgical cut down and with a short prosthesis where it is inserted. And so that's how we do it, because we think it's the most benefit for the patient to generate this cardiac output of 5.5 liters per minute. But may I also ask a question to Emiliano?
Great.
You decided to treat only the left coronary artery. What about the right coronary artery? Do you think the patient might benefit from additional revascularization on the right coronary at some point?
Sabine, this is a very interesting question. Long story short, I don't know the answer. But looking at pathophysiology, this patient didn't have a three-vessel disease. This patient had one critical vessel disease, which was left main, which was supplying the entire heart blood, because actually due to the CTO of the right coronary artery, also the right coronary artery territory was suffering. So I'm not saying that performing a revascularization only on the left system have saved him, because it's of course he still has this chronic coronary occlusion, but of course it has a re-established coronary flow also on the right side. I wonder if this patient if this patient is getting better and better, maybe we could perform a CPET to assess also his function under stress, because this is another problem. We always think about resting conditions. So now we think that in a resting condition, right, coronary artery occlusion is not a problem because it has collaterals, but this might not be true under stress. So we will see. We will follow him, and I will let you know.
I think it's a difficult question, but you answer very well. So I think it's time to deliver the key messages for this very, very interesting webinar. And I would like to thank all the experts and all this discussion for the, and I leave after the last word for Amina. So my messages just before. So first of all, it's to say that when you have a coronary artery disease associated with the heart failure with a reduced ejection fraction, the patient has a higher mortality, higher risk of hospitalization for heart failure, and also a progressive LV dysfunction, for an aggravation of the LV dysfunction. When you perform a revascularization, that might improve the prognosis, but as we understand with Martha, it's the CABG is the first choice following the recommendation, the guideline recommendation. However, PCI could be an alternative to CABG based on coronary anatomy, based on comorbidities of the patient and the surgical risk. So the necessity, absolute necessity to have a heart team discussion. And we saw that mechanical circulatory support use should be individualized to the patient. But for the last, I love the sentence of Martha, and I think it's we have to choose a strategy allowing a complete revascularization with the lowest overall risk for our patient, and while preserving the opportunity to optimize the medical treatments. So, Amina,
Thank you very much, Martin. So first of all, I would like to say thank you very much to my co-chair, Martin Gelari. And also I would like to thank all our esteemed discussant and speakers. Thank you very much for this wonderful 1-hour webinar discussing a very difficult topic on a chronic heart failure with reduced ejection fraction and chronic coronary syndrome. Thank you very much.
It's been a pleasure.